Good evening, dear colleagues, ladies and gentlemen. It is a great pleasure for me to host this UEG education platform and today webinar's first ever webinar of intestinal failure in Crohn disease, a challenge for artificial nutrition and medical therapies. I kindly ask you to confirm, can you hear me?
Yes.
Of course, I would like to introduce our experts. First of all, Professor Alistair Forbes, visiting professor in Tartu, Estonia now, coming from Norwich, University of East Anglia, UK, a really well-known gastroenterologist, IBD expert, and a real expert in intestinal failure and short bowel topic. Also, another one is coming Stefan Schneider, Professor Stefan Schneider, gastroenterologist coming from Nice, France, very famous gastroenterologist, IBD expert, and also very experienced in the field of intestinal failure and short bowel. So we are extremely happy that have such two such prominent persons with us tonight, and I'm quite sure we will enjoy in these in those presentations. I would like to ask all of you to be very active, to send the questions and use the chat function. We will be happy at the end to try to answer to your questions. If not tonight, then you will have a chance to send your question to us. And I also ask you to understand us. If any technical problem will arise, we will try to solve that immediately. And now it's time to start with the topic. First, Professor Forbes, dear Alistair, I kindly ask you to give your presentation.
Jellicoe, thank you very much. Thank you to UEG and to the whole team for putting this on, and my own welcome to the audience. Our next slide is a disclosure slide, and clearly you've heard that we're all three of us gastroenterologists, but we've also, all three of us, got very close affiliations with ESPEN, the European Society for Clinical Nutrition and Metabolism, and take a big role in its educational activities. I think that's probably the most important conflict, in inverted commas, for us to declare. But I don't think there's anything that interferes with the content of the meeting. So, intestinal failure. You all know about Crohn's disease. I don't need to tell you what Crohn's disease is, but it's probably helpful just to be clear that we know what we're talking about when we talk about intestinal failure. This is a simplified version of the slightly longer ESPEN definition. But in essence, intestinal failure is the condition where a patient can only maintain normal fluid and nutritional balance by the administration of intravenous support. You've heard I'm now in Tartu and Stefan is in Nice, and I was rather pleased with this pair of slides because it demonstrates that even in October we can have nice blue skies that almost rival those of Nice, despite the changes in latitude.
Almost.
Almost. So, I've told you what intestinal failure is. What I haven't said is that intestinal failure and short bowel syndrome are the same thing, because they're not. In many patients, intestinal failure is indeed a consequence of short bowel. But Crohn's disease is one of the exceptions to that general rule because it may not be just short bowel, and indeed in some patients it may not be at all. So the pathophysiology of short bowel syndrome is generally speaking obvious, and I had a slide that we were going to show you of a surgical team clearly responsible for short bowel syndrome, but for legal reasons I'm not allowed to show you that to you. The inadequate functional intestine to allow normal absorption is the key here. A failure to reabsorb gastrointestinal secretions. If you have had 3/4 of your small intestine removed, it is likely that you're going to have a few problems. Without treatment of intestinal failure, the patient will die. There's no need for controlled trials. If there is insufficient intestine, without intravenous support, the patient will die. That's the context we're dealing with here. Short bowel, of course, doesn't necessarily imply any surgical error. Interestingly, in the particular context of Crohn's disease, people used to worry that it's one operation and another operation is 10 centimetres here, 20 centimetres there. It is very, very rare that short bowel occurs in Crohn's disease because of multiple nibbles like that. It is usually one catastrophic resection, and usually in the context of other problems as well. So it's a context of severe sepsis and a big operation. And our interest is in how much of the bowel is retained. Surgeons are very good at telling us how much they've removed, less so at telling us how much remains. And that's important because the normal, healthy small bowel has quite a variable length from one person to another. And if the patient starts off with 6 meters and loses 3, that's not a big deal. But if they start off with 3.5 meters and lose 3, that's a disaster. So we're always interested in how much bowel is retained. Surgical errors do exist, do occur, of course, but that's the minority. It's usually disease and bad disease that's responsible. And I've said intestinal failure isn't synonymous with short bowel, because we're also interested in the functionality of the remaining intestine. And that's a particular issue in Crohn's disease, because you can imagine that someone who's got a metre of completely healthy small bowel might function quite well. But someone who's got a metre of Crohn's disease with a lot of inflammation, poor absorptive capacity, might be in a lot more difficulty. And indeed, occasionally, someone even with 2 metres of small bowel that's affected with Crohn's disease will similarly be dependent on intravenous support. There are 2 main classifications of intestinal failure that are used. One is essentially anatomical, and the other has more to do with the severity and the time course and a prognostic route. Rather confusingly, both classifications describe intestinal failure as types 1 to 3. So to avoid, or at least minimize confusion, I'm only going to give you the numbering for one of them. So this is the anatomical classification. And the types of short bowel that we most often see in Crohn's disease are patients that have either had a substantial small bowel resection with a part of the colon removed, but enough of the colon remaining that it's possible to do a jejunocolic anastomosis. The other group are patients that have an end jejunostomy. It is true that some of those patients may have retained distal bowel that's out of continuity, and that's something that we'll come back to in discussion at the end. This is the other classification that has more to do with the severity and the prognosis. Type 1 is what you might think of as an ordinary post-operative ileus. Pretty well anyone that's had a major abdominal operation will have this sort of post-operative ileus. Every surgical unit in the world is used to it. It gets better on its own. They might need a little bit of support for a day or 2, but broadly speaking, it gets better on its own. Type 2 is the catastrophic, prolonged intestinal failure, often with sepsis, may be associated with enterocutaneous fistula, lasts for weeks, if not forever, and is often very, very complicated, very difficult to deal with, and can be fatal. There's then type 3, which is stable but long-term, where the patient's in need of essentially permanent intravenous support. That can follow well-managed type 2, of course. In Crohn's disease, we should be anticipating intestinal failure. I've told you, the patient with a stoma, and a patient with less than 200 centimetres of small bowel leading to a stoma is at risk. Less than 150 centimetres with some of the colon in continuity is at risk, and anyone with a high output, either from a stoma or a fistula, of more than 1.5 litres a day is again at risk. Doesn't mean that those patients automatically have intestinal failure, automatically have a need for intravenous support. Because if the residual small bowel is healthy and they're well managed, it can be avoided. But all those patients are high risk. We also need to think about the patients with Crohn's disease who don't have short bowel at all. There may be patients with intestinal obstruction or intractable pain that prevents eating, or fistula behaviour, particularly a very high output fistula that is difficult for the patient to manage, or occasionally someone with perhaps a vaginal fistula or some other fistula that makes control of the fistula output very, very difficult, such that the patient simply stops eating in order to make it tolerable. So in those situations also, there may be intestinal failure and a need for intensive nutritional support. Just think for a moment about normal gastrointestinal volumes. Food and drink, around about 1.5 litres, saliva, gastric secretions, all the other secretions, totaling about 8,000 mils a day, but only 100 mils in the stool, in a normal person. Think of it in the context of, I don't know, maybe vodka would be a good thing to think about. 8 litres of vodka is very, very different from 100 mils of vodka. And that's the difference that we're talking about in terms of the secretions into the upper part of the intestine and what's left over after the normal processes of reabsorption. So secretion is predominantly proximal. Metabolically interesting things may also be proximal, but the absorption and reabsorption of fluid is predominantly distal. So you could imagine a hypothetical stoma halfway along the small bowel, 8,000 mils a day coming out without there being anything wrong with that patient at all, because that distal capacity for reabsorption has been lost. So we've got two main types of short bowel patients. The absorbers, where the output is less than the fluid intake, and their output will generally be less than 2 litres, generally a lot less than 2 litres, like all of us, and somewhere down to the normal 100 mils of stool volume. The secretories, however, have a problem that their output is greater than their intake, with an output usually greater than 3 litres. And that leads to this very important concept of net absorber or net secretor. On the left, we have a healthy person who's a net absorber. And if that person gets dehydrated, they become thirsty, they drink more, they increase their fluid retention, and the problem is resolved. Whereas on the right, we've got a patient with a short bowel who also becomes dehydrated. The same mechanisms make them thirsty, the same mechanisms make them drink, but that leads to increased fluid losses and therefore to deterioration. And that becomes the central challenge of short bowel syndrome, the thing that makes short bowel syndrome management difficult because it's counterintuitive. So fluid restriction is the central challenge. When the patient is thirsty, they need to drink less. We can use urine sodium to pick that up at an early stage because that's the most sensitive of the various investigations available to us. There is marked sodium retention in dehydration. It's very early, it occurs long before any of the other blood tests become abnormal. You don't need a timed sample, it doesn't need a 24-hour urine or anything. 200 microliters is enough, you only need a teaspoonful. But if you've got a concentration of sodium less than 20 millimoles per litre, that's pretty well diagnostic of dehydration. It doesn't mean they've got short bowel necessarily, but it's telling you that they have dehydration. That's a very, very useful diagnostic test, and it's a very useful management tool for telling you whether you've got it right in your management. So what are we going to do? We're going to address salt intake. We're going to resuscitate the patient with intravenous sodium-containing fluid. I put saline in inverted commas because we generally don't like to use saline. We like to use a concentration that's lower in chloride because particularly the sick patient has more difficulty in clearing excesses of chloride later on. And we're going to reduce the oral intake of low sodium fluids, which effectively means all fluids that the patient wants to drink. There is nothing that ordinary people drink that has a significant sodium content. And we're going to try and increase the sodium intake in general. We're going to do that by putting salt in fluids or salt on the food. Now, you can tell me. Most of you as children will have put some salt in your father's tea or in his coffee instead of sugar. And that's disgusting. I've yet to find anyone that likes salt in tea or coffee. However, if you put extra salt on your McDonald's fries, most people seem to find that quite acceptable. And indeed, the short bowel patient will often find that's actually even desirable. So we're going to concentrate on getting salt into the patient by putting salt on food, and we're going to encourage regular food intake. high energy foods, separating food from liquid because that seems to help the overall fluid balance, and we're going to eat little and often, which brings me to my next slide, and I hope we might have a video to go with this, so that the video should hopefully show you this very nice Croatian cow. It doesn't matter if the video doesn't run, but what the point about it is that the cow is eating. The cow is eating, and it goes on eating. The video lasts for a couple of minutes if we let it run all the way through, but the cow is there chewing away, and the reason the cow is chewing away, you can turn this down in the video, the cow is eating and goes on eating and eating and eating and eating and eating and eating and eating, because the nutritional value of the grass is very important. But if the cow eats all day long, then the combination of the healthy gut and the time allows adequate nutrition. In the patient, we have a different context. We have perfectly good food, but a non-functioning or poorly functioning intestine. But if we use time in the same way, once you've explained it that sort of way and illustrating it and describing it to the patient as cow therapy, because it's funny, the patient finds that something they can relate to, and that's quite helpful in management. We've also got a number of other non-pharmacological elements that we can introduce, including, crucially, oral rehydration solution, which needs to be the old style World Health Organization solution with 90 millimoles of sodium. And as I say, we're going to encourage oral feeding with real food. It's actually better to use food because it's dry. We occasionally use formula foods, we occasionally use tube feeds, but never elemental, because elemental's got everything wrong about it. It's high volume, low energy density, and most of all, it's hyperosmolar with a very, very high osmolar load that increases fluid secretion into the intestine. That's exactly the opposite effect. I'm now going to hand over to Stefan to say a few words on pharmacological interventions, and then I'll come back to say a few words longer about the parenteral aspects.
Okay, thank you, Alastair. Well, I mean, fortunately, we have a number of pharmacological options in these patients, with the main aim being optimizing absorption. And these are all drugs, that you all know and use. The first ones are anti-secretory drugs, because all these drugs match the pathophysiology of intestinal failure in these patients. And Alastair told you that the problem is how to reabsorb all these secretions when the intestinal continuity is so short. And it makes sense to reduce the secretions, and you saw that a big part of the secretions come from the stomach. And that's why the use of PPIs, but also H2 blockers can be advised. We know that in short bowel syndrome due to mesenteric infarction, there is an acute hypersecretion in the first weeks that then usually resolves partially. In Crohn's, it may last longer, and you may have to use these drugs for a longer time. The other thing is, okay, we want absorption, we want the nutrients to be less diluted, hence the anti-secretory drugs, but we want also better contact between the nutrients and the brush border. And therefore, it's useful to slow intestinal transit to increase the time. And hence the importance of anti-motility drugs. Of course, you all know loperamide that you use in acute diarrhea and in some case of motor diarrhea, chronic diarrhea. But you may reach important dosage in short bowel syndrome patients, and that can go up to, usually we use up to 40 milligrams per day, but some colleagues use even more. So you can use loperamide, you can use codeine phosphate as well as a syrup, or you can find it in combination with paracetamol. But the very important thing in these patients, Alastair told you about the functionality of the remaining intestine. And of course, it's going to be a huge difference between 1 meter of diseased gut and 1 meter of healthy gut in remission. And so I think we need to mention here the importance of therapies, nowadays more and more biological, to put these patients in remission. Now, there are all other pharmacological options, probably less important, but they can help a lot. First thing is providing calcium. Of course, there are going to be a calcium deficiency enhanced by vitamin D deficiency. So you may partially cope with it, but calcium has another very good interest. It's that it's able to bind lipids, for example, and binding lipids will help you not will help you with diarrhea, but it's mostly important that lipids and calcium will bind oxalates too. And when the colon is in continuity, there is an increased absorption of oxalates, and that can lead to nephrolithiasis. So it can be important to provide calcium, say, thrice a day to bind oxalates in the food. Some patients, even those with short bowel syndrome due to Crohn's, develop small intestinal bacterial overgrowth, and you may help them with giving them non-absorbed antibiotics such as vancomycin or gentamicin. And last, there is still a problem that was called parenteral nutrition associated liver disease, which is now called intestinal failure associated liver disease, IFALD. And among the possibilities with, I would say, a rather low level of evidence, you have ursodeoxycholic acid that you may provide these patients. So you see with drugs that we are used to employ in these patients, we can help a lot, many patients. However, of course, this is not the basis of their treatment in these patients when they reach SBS-IF. And of course, the basis is parenteral nutrition, Alastair.
Thanks very much. So we try to avoid parenteral nutrition. We try to manage the patient as best we can with all the measures that Stefan's told you about, in combination with that careful fluid balancing. But if they have intestinal failure, then they are going to need parenteral nutrition. And there we're aiming for the minimum that's needed, not the maximum. We're always aiming for supplementary parenteral nutrition. Now, just put that in context, because we're talking in Crohn's disease about a chronic condition. And when we're talking about intestinal failure in Crohn's disease, we are usually talking about a permanent condition. It's not that common that it's possible to do something surgically that reverses the problem. So we're talking about home parenteral nutrition. And in most series now, home parenteral nutrition is preceded by major mesenteric infarction or some degree of post-operative complication. And in the recent international series, we're seeing around about 25% of home parenteral nutrition being needed for patients with Crohn's disease. So this is despite all the advances in Crohn's medication, therapy in general, better surgery, all the things that we do better in Crohn's disease than was possible 20 years ago. Still, we've got a percentage, around about a quarter of all the patients, certainly of those with benign reasons. And for reasons that have not ever been very clear, it's always been very much more common to need parenteral nutrition for Crohn's disease in some countries than others. And it's perhaps appropriate that we've got a French speaker and a British speaker today, because historically the frequency has been highest in the UK and lowest in France. And I think it's fair to say that in both countries, they're coming towards the mean. So probably it's a convergence of practice rather than a convergence of patients. So let's just look at parenteral nutrition in those patients with Crohn's with a need for intravenous support. It's not too different from parenteral nutrition in any other context, except for three things. It is very common to need high volumes, and we're not talking about 2.5 litres, we're talking about at least 4 litres. And I've got one patient with Crohn's who has a daily requirement of 7 litres. There are other things that are confusing and puzzling about her, but it's common to need 3.5, 4 litres a day. They also need a high sodium content because they're losing sodium from the intestinal losses. The stomal losses have a high sodium content, typically about 100 millimoles per litre of stomal effluent. So it's common to need 250 or more millimoles per day. And they also need a high magnesium. Aside from that, pretty typical to other long-term parenteral nutrition. We're careful about soy lipid, and we're careful about the long-term parenteral nutrition prescriptions, as we would be in any other group of patients. But one thing that's perhaps worth mentioning, because it's occasionally a source of confusion in quite good nutrition teams that fret about giving too much. So if you think about a patient who needs a arbitrary 2,000 calories a day, they've got short bowel, an absorption of 50%. So they eat 2,000 calories, and we're encouraging them to eat. So they eat 2,000 calories, and they absorb 1,000 of that. So that patient is going to need 1,000 calories parenterally. And that's where the confusion comes in, because someone will come along and say, hang on a minute, this patient's getting 3,000 calories a day. That's too much. That's hyperalimentation. That's bad for them. It will give them liver disease. Of course, that's nonsense, because the patient is only getting 2,000 into their circulation, the correct 2,000 that they need. It isn't as simple as that, because we rarely know exactly what the percentage of malabsorption is. And of course, the percentage of absorption of dietary carbohydrate is different from the percentage of dietary fat, or indeed of any of the micronutrients. But the principle there is one that one can follow quite easily. So remember that we will usually be appearing to give a lot more nutrition than the patient actually needs. And of course, that's taken to its extreme example in the patient who is fantastically good at this acquired hyperalimentation by eating more. And you'll get the occasional patient that manages to eat 4,000 or 5,000 calories a day on a continuing basis and can therefore avoid the need for intravenous support. And of course, that applies to all the nutrient groups. So it's not just calories that we're talking about. Exactly the same argument there applies about nitrogen or indeed any other nutrient. I'm going to finish my section now just with a note that Tartu becomes the European capital of culture in 2024. And hopefully by then we'll have got rid of COVID and it will be an opportunity to invite everyone to visit us here. And I'll hand back to Stefan at that point to continue with some more interesting therapeutics.
I wouldn't say they're more interesting, but I would say they're part of a whole strategy these days. And you know, taking this very interesting graph from Palle Jeppesen, who I will be mentioning often enough, you see here on the y-axis you have how much you need in terms of fluids or nutrition, of parenteral support, and there in the x-axis you have the degree of malabsorption, considering it's very heterogeneous. The worst case scenario is the full intestinal failure here, where you're really dependent. 7 nights a week, you need to receive parenteral nutrition. And then the improvements will come through promoting lactation, will come with, reducing the amount that can allow patients to reduce time. I mean, they're going to move from 3 liters to 2 liters, so they're going to gain 2 hours per night. And then they will be able to get 1 day or 2 days off, maybe even more. And then look, when they reach the threshold between intestinal failure and insufficiency, which is basically short bowel syndrome not requiring parenteral support, then there's a huge increase in quality of life. And these patients can even be kept off parenteral support. And you see that most of it comes for a start through developing hyperphagia. So researchers have tried to find a way to help this adaptation. It can be spontaneous, once you develop short bowel syndrome, there's a significant probability of being weaned off over the next couple or maximum 5 years after. But how can we help? And so researchers became interested in the enterohormones, hormones produced through gut stimulation. And especially here you see GLP-2, which is glucagon-like peptide 2, but also GLP-1. Both are synthesized through proglucagon. And the interesting thing you see they are produced in the terminal ileum and also in proximal and distal colon, the L cells, through stimuli, nervous and hormonal stimuli, due to the arrival of nutrients. And you see that both GLP-2, GLP-1, and also PYY have an effect of slowing the intestinal transit, prolonging intestinal transit time, and also delaying gastric emptying. So that's very interesting. And you know that this is part of the effect of GLP-1 in type 2 diabetes, for example. But GLP-2, and that's not true for the other two guys. GLP-2 also has a trophic effect on the anthrocytes. And actually, a few years ago, you see, still our friend Pale Jeppesen, 20 years ago, he published his first study in which he administered a native GLP-2 to SBS patients with Crohn's, SBS-IF patients with Crohn's, and he was able to see an increase in energy absorption and macronutrient absorption, but also, this is in another slide, an absorption of water and electrolytes, wet weight and electrolytes, were more absorbed in patients treated with this hormone, with this antral hormone. And so the follow-up was, okay, let's try to change it. What researchers did was to substitute, using the recombinant technique, substitute one amino acid, a single one, glycine, alanine being substituted with glycine in position 2. And this rendered the molecule, the peptide, resistant to degradation by DPP4. You know that GLP-1 and 2 are degraded by DPP4. And so while increasing its resistance to degradation, of course, the half-life went from 6 to 7 minutes to more than 2 hours. And of course, with greater maximal effects than native GLP-2. I need to mention here that this drug, teduglutide, has also been tried. So you have many case reports in which it was showed that it may have an anti-inflammatory effect in Crohn's patients. Still, it's weaker than the other biologicals we use these days, but it was important to mention because these patients still have both SBS-IF and still active Crohn's disease for most of them. So there were 2 big randomized control studies, and I'm showing you the design of the second one, which was actually after screening, optimization, stabilization, to run a placebo-controlled study, and then for 24 weeks, and then follow up with an open-label study where everybody was receiving the drug. What are the results? Well, FDA asked to show difference, with the main outcome measurement being a reduction by at least 20% of weekly parenteral supple volume after 20 weeks, confirmed at 24 weeks. And you see that this outcome was reached in twice as many teduglutide-treated patients compared to placebo-treated patients. Still, it's not very visible to all of us, and so I think this is easier to see. You see the mean change in parenteral nutrition volume over time until the week 24, and here's you see even in placebo patients we try to force the outcome by trying to reduce, and we're able to reduce in some of the patients, but there was a significant difference, 2.1 liters per week. And that was the average difference. 2.1 liter is usually 1 bag, so 1 free night of PN. What about the long-term effects? I was telling you that there was a follow-up study of 2 years, 24 months. And actually, in this study where all patients were carefully selected for this RCT, you see only 12% of patients were able to be weaned off PN. And you see it could take time. It took a median 89 weeks, nearly 2 years, for patients to be weaned off. But those who were weaned off actually, the decrease was able to start very early or very late. So you see the heterogeneity, even the heterogeneity of the the short bowel length. I mean, the patient with 26 centimeters was a patient of mine, and we were able to wean it off PN, feeding him enterally, of course, not only orally, but still we could do it. But at that time, with these factors, there was no predictive factor. Well, now more and more people are using teduglutide in SBS-IF, and this is the French cohort that we reported recently. We took all the 54 patients who had received the drug for more than 6 months, and thanks to all the friends in the country, we were able to get 100% of the patients. And we compared those weaned off and those non-weaned off. And first thing you'll see is that we were able at week 24 to wean off already 24% of the patients, which was a much bigger figure compared to the randomized controlled trials. And this is comparable to the experience of other colleagues worldwide in real life situations. What were the factors associated with being able to be weaned off? You see that actually there was no significant difference for Crohn's patients, 0.06, but didn't reach significance. What was significant in both univariate and multivariate analysis is that if you had a jejunostomy, no colon in continuity, it was more difficult to be weaned off. If you add more fluids infused daily, it was more difficult. And if you didn't eat much, it was even more difficult. All this was statistically significant, which means that when you have a colon in continuity, when you're able to develop hyperphagia, and when you require a smaller amount of parenteral support, the drug will help you better be weaned off PN. I'm not talking about the response, but just for people being weaned off. Are there contraindications? Well, of course, hypersensitivity. This is a growth factor, so any active or suspected malignancy or any history of malignancies of the GI tract, including the hepatobiliary system and pancreas, within the past 5 years will contraindicate the drug. Now there are situations such as severe heart failure, such as radiation enteritis, for which in our daily life, in real life, we try not to use the drug, but these are not formal contraindications. What about the side effects? There has been a very important and comprehensive study published recently. I'm referring to a former study that shows the responsibility of the treatment. You see any treatment emergent adverse event. I mean, most patients are concerned mostly with, I would say, banal digestive symptoms. Usually due to the treatment, but usually that's self-resolving after a few days or weeks. Still, some led to discontinuation, and we saw 3% of death and 3% of malignancies leading to death, and these were considered to be cancers already starting to develop before the patients were treated. Now, I was telling you about how teduglutide was built by substituted one amino acid. There are new generations of drugs in this family of GLP-2 analogs coming up in the market, undergoing randomized controlled trials at the moment. They're all moved or moving to phase 3 trials. And the first one is glepaglutide, and you see actually the reduction in both in fecal output with 2 dosages, 3 dosages, and the increase in urine output, which is like a mirror image of the previous one with the 2 doses. And actually, the important thing about this one, glepaglutide, or the other one, apraglutide, is that more amino acids were substituted, which boosted the half-life from 6-7 minutes, not this time to 2 hours, but to between 30 and 50 hours, which is very interesting. Now, I was telling you about the interest of reducing gastric emptying, slowing it down. And this is something that GLP-1 analogs can also do. And there was a very small study, a very small ancillary study that showed the interest in 5 SBS patients of GLP-1 analogs. But this one was considered to be the only one reducing intraduodenal motility. But there is a potential interest for combining both GLP-1 and GLP-2 analogs. So that's also something that may be interesting in the future. Now, this was drugs. Let me say a few words about surgery. Surgery plays an important role in adaptation, especially for reestablishing continuity. And this is something that is very important. Of course, for a patient with a Crohn's colitis, an active Crohn's colitis, you're not gonna perform the continuity if the patient is still active in his or her colon. But once the patient has healed, if the small bowel is too short, you're able to harvest up to 1,000 kilocalories per day thanks to the colon. So, okay, you know that there is a risk, especially for patients with perineal lesions, there is a risk to induce a flare-up, but still it needs to be done as soon as possible once the mucosa has healed. And there are also some rehabilitation surgical techniques we can address during the discussion. What about transplantation? A few words about it. Intestinal transplant for SBS-IF can be performed, but and this is a European survey led by Espen and Loris Pironi. They compare the survival of patients that the participants deemed to be needing transplantation. And you see that compared to non-candidates, only those not transplanted were dying more only if they had desmoid tumors or intestinal failure-associated liver disease. The rest was not significant. So these days, intestinal transplant is less and less considered as an interesting option in these patients. And as a result, you see here the transplants in Europe between 2013 and 2018. This is from the intestinal transplant registry. And you see that apart from Cambridge in the UK, there are really few places doing it anymore. So to finish, this is my hometown. I still think it's warmer and with more sun than Tartu, Estonia. But I mean, I think the good thing is traveling, meeting people, meeting friends, which I hope we can do very soon. And as take-home message, we saw that, well, SBS-IF is very rare in the evolution of Crohn's disease. But when you take a cohort of SBS-IF patients, you have many Crohn's patients still worldwide. Colon incontinuity and non-diseased gut do matter a lot. The provision of energy and proteins, but also water and electrolytes matters. HPN is at the heart of treatment, and we haven't seen that, but it needs to be done by a multidisciplinary team, ideally in expert centers. We saw the importance of dietary measures, anti-motility drugs, very simple ones, but easy to forget, and also the potential interest of GLP-2 analogs.
Now we can go to the question. I know that Alistair, I got information from Alistair, but it is really nice and kind from him that he sent several answers to the questions which we got through the chat. Maybe, Alistair, maybe you can just, because you did on the private, can you make it openly now?
Yes, of course.
Yes.
So I had a number of actually very good and thoughtful questions. If I just scroll back through the chat line, and I can address them in the order they came. So I was asked.
I cannot hear Alistair.
Can you hear me?
I can hear you.
Yeah. So I was asked about the approach to a patient who's not allowed to take food, and to be honest, that's incredibly unusual in a patient with Crohn's disease. I mean, our patients with intestinal failure, we are desperately encouraging them to eat. And we want them to eat because we want them to maximize their gastrointestinal function, and because it's more physiological than anything we can do parenterally, and because food is so much easier to manage from the fluid balance point of view than any of the sort of liquid artificial feeds that are actually more difficult to use in this context than ordinary food. So the only time that we've got a patient who's going to be nil by mouth in the context of Crohn's disease is either someone who's just had an operation and who might have an intestinal leak. So that's one group. The second group is really the patient who's got an unresolved stricture, who's awaiting surgery. And so that's another group. But that patient's going to be complaining. They're not going to be wanting to eat. I can't think really of any other patients where we actually say, do not eat. There's the occasional patient I mentioned in my talk with a difficult fistula, particularly a vaginal fistula that's leaking and impossible to manage. That patient will sometimes choose not to eat, but it's not us telling them, it's them choosing not to. So as far as Crohn's disease is concerned, that's not usually a problem. The patients that we have to tell not to eat, very, very few and far between. But of course, the follow-on to the same question was, do we need to get... You really need the food. We do have the longer-term question of psychology in these patients who've got chronic illness, and psychological input is clearly very helpful there. That really also addresses the question of another questioner about the use of enteral nutrition, which again we pretty much avoid, and it's again really a stricture that we think about enteral nutrition, because if they've got intestinal failure, then we are aiming to avoid enteral nutrition because of the fluid balance point of view. There was another good question about how we make the assessment of what the patient's degree of absorption is, and of course that's really difficult. And I gave you a very stylized example of someone with a terribly neatly 50% malabsorption. It's not like that in real life. It's rare that we've got a very clear idea. We've tried a variety of different methods to improve our ability to assess that, and one of my research interests has been in the use of citrulline to try and use a biomarker that says this patient's got really bad malabsorption, this patient's malabsorption isn't so bad. But the problem with citrulline and most of the other attempts at measuring it give you good distinction between populations, but they don't actually give you a good distinction between individual people. So as far as fluid balance is concerned, we can do that pretty well, and we're fairly good at that. But when it comes to nutritional balance, you can do very, very detailed nutritional balance, what are effectively experiments. I'm going to call them monitoring, but it's really so intensive that it can only really be done at an experimental level. And there are very, very few units in the world that are capable of doing that. Pally Jefferson's group in Copenhagen is extremely good at it, but there are very, very few centres that can do that on a routine basis. So largely it's down to seeing what happens. You make a rough prediction of what you know about their anatomy and what you think the state of the residual intestine is like, and you make an estimate on the basis of that, and then you see what happens. And if they gain weight slowly, that gives you an encouragement that you're probably on the right level. And if they're not gaining weight, that equally draws your attention to look and say, well, maybe their absorption is worse than we thought it was. Or, particularly in the case of Crohn's disease, and again, Stefan mentioned this quite early on in his talk, there is this question of the activity of the Crohn's disease. Mostly, by the time patients have got intestinal failure with Crohn's disease, the Crohn's is largely gone. It's largely burnt out. There's not much intestine left. But some patients with still a lot of residual intestine can have active Crohn's disease, and their nutritional problem is not only intestinal failure, but also a catabolism of an active inflammatory disease, and we need to think about that as well. And I think those are the main things that happen.
Thank you very much for very comprehensive answer to several important questions. We should find something for Stefan. I'm quite sure.
On the
for
drugs.
example, Stefan, I got a question from Dina, and Dina asked me, what do you think about some new trends and some rumors about use of some GLP-2 analogs in the treatment of the patient who are taking home enteral nutrition exclusively? Is there in the situation of the short bowel, does it make any sense to increase absorption or not?
I would say it does in a way, but the thing is that, okay, you want to reduce as much as possible the parenteral support. So you need to develop hyperphagia. The problem is that, and especially with these GLP-2 analogs, some patients cannot develop hyperphagia because of the because of the delayed gastric emptying it induces. So actually using enteral nutrition may be a good way to provide enough so that combined with the mucosal hypertrophy due to the GLP-2 analog, the absorption will be more optimal. So it would make sense. It hasn't been tested like that in studies.
Yeah, thank you very much. And Alistair mentioned a bit of use of citrulline as a marker of. Do you have some suggestion for us and auditorium about that?
It's
interesting, isn't it?
Yeah.
It is. Maybe it's when I was partly disconnected, I couldn't hear you or see you. But I mean, it's been overall, when it was first described by the Paris team, it was very exciting because the enterocyte will make citrulline from glutamine, and then the kidney will transform citrulline in arginine. And so, I mean, on paper, like so many nutritional concepts, it's very exciting. The thing is that as a treatment, it has failed in most situations of intestinal failure. And as a biomarker, I think it lacks sensitivity and specificity, unfortunately. Don't forget that if you have any degree of renal failure, you're not going to be able to interpret it. So it's, we still measure it. If it's below 20 micromolar, we're going to say, oh yeah, this patient will always require PN. But more than that, we don't know, unfortunately.
And I think that's absolutely right. It tends to be very obvious when the clinical picture is very obvious. Yes. And it's fine for looking at populations of patients. If you've got 100 patients with short bowel, the citrulline level will correlate very well with the amount of parenteral support they need. But if you look at individual patients, it's really not on its own sufficient. And I think we need to be looking at combinations of things.
Yes.
And that's something that the ESPEN special interest group is looking at quite actively alongside the group of European intensive care specialists, trying to see if we can use combinations. One suggestion being the intestinal fatty acid binding.
Yes, very, very good suggestion. Yeah, definitely.
And it looks a little bit better than looking at either of them on their own, but it's not enough. And probably the way forward is, in the intensive care context, building them into something along the lines of the Apache scoring or the SOFA scores as additional prognostic markers, but on their own, I think that they're not, as I said, they're not either sensitive or specific enough on their own.
Yeah. Is there any room? Yeah, Alistair or Stefan, both. Is there any room for historical dextrose tests?
I do it in all my patients.
Well, it's interesting. I mean, when I was a trainee, we were taught about the xylose tolerance test. And I learnt it as the rule of fives, that you used 5 grams, you collected the urine for 5 hours, and you expected there to be 20%, i.e. a fifth recovered. But I think I'd also add another fifth to that. It's only accurate about a fifth of the time. It's nothing like sensitive enough. It's simply not discriminatory enough.
We have a time shortage now, and maybe a few quick answers.
Jericho, excuse me, if I may, because I wrote.
Yes, of course you can.
Somatostatin, you know, and
that is what I really like to add.
And sorry, webinar public and friends for that, because I wrote it. I wanted to talk about it. Somatostatin, I mean, this is a very potent anti-secretory drug at several levels, at mucosal, at pancreatic, at biliary levels. And the thing is that it may help, but what about the long-term effects? The thing is, this is, and you know that somatostatin analogs were historically used and are still hard to as an anti-growth hormone treatment. And when a key problem of the patient is malnutrition, this is an anti-nutritional treatment that may also worsen known diabetes, for example. So that can be useful, but on the very short run, not on the long run. Now, of course, if there is a fistula, this is a very different situation, but this is going to be an acute treatment, not a chronic one.
Thank you so much. It is very important because several people really ask about that. So we are 1 minute to go, and I would like to thank both of you, Alistair and Harry, and of course Stefan, for your excellent presentations. I really enjoyed that, and I'm totally aware that participants also like that very much. So I would like to once again to stress our next meeting, which is Best of Postgraduate Teaching from UEG Week. It will be 27-28 November on the UEG webpage. So also I would like to stimulate participants to join my UEG. This is really Europe's largest community in digestive health. So ESPEN is also very proud to be under the umbrella of UEG, and our activity is a part of that. Everything is more or less for free. So even this presentation and even, yeah, bravo. And even this activity will be available through the YouTube, and it will be available on the web of UEG. And if you like to interact more with UEG, and especially UEG education, there are several links here, like Facebook, Instagram, Twitter, LinkedIn. So huge potential for activity. Once again, thank you very much to all participants, and of course to Alistair and Stefan to be with us. Thank you, my dear friends, and it was great time to spend with you this evening. Thank you very much. Bye.
Thank you. Bye then.